She's worked incredibly hard to make this CPD a success for us today. She's none other than Dr. Sayuri Pereira from Sri Lanka. Madam, over to you, please, for the next part of the session. Thank you.
Thank you, Dr. Rajashree, Dr. Gautam Saha, and all other dignitaries. A very good evening from Kandy, Sri Lanka. It's my absolute pleasure to introduce Professor Thilini Rajapakse. She's the Chair Professor of Psychiatry at the Faculty of Medicine, University of Peradeniya. We are colleagues, we are friends, and she is a well-known academic and clinician. I think she's trained many registrars, senior registrars in psychiatry, and she has contributed in many ways, I would say, to the College of Psychiatry. She's been the past secretary, she's worked as editor-in-chief, and I think the list is too long. Her name is well known in Sri Lanka and as well as in other SAARC countries and indeed nationally. I won't take up much time. Thilini, thank you so much for agreeing to do this. And we are really looking forward to hearing you deliver this CPD lecture. And I think there will be a Q&A session at the end of this, which I will moderate. Over to you, Thilini.
Thank you. Thank you very much for that very flattering introduction. And thank you also to the SAARC Psychiatric Federation for having me here today. I'm quite honored and flattered to be the first person at the CPD lecture series. Just give me 1 minute while I try to share my screen. I think I am sharing my screen now. Can you see it?
Yes, it's visible.
Okay.
Can I make it present? Yeah, good.
Fine? Okay, all right. So I've been invited to talk about this topic, which I think is familiar to all of us. I mean, it's something that is universal and human, and part of it is not a disorder. But I'll just take you through the basic concepts, particularly keeping the trainees in mind. So when we talk about grief, really what we are talking about is it's the reaction, the involuntary sort of the gut reaction that we get when we lose somebody that we care about. Usually it refers to the reaction, the emotional, behavioral reaction you get when somebody you love dies. And it is one of the most basic experiences. It's something that we all go through at some point in our life. The only way to avoid it, the books will tell you, is not to care for anybody, which is hardly an answer. And there's been a lot of writing about grief, both academically and also in the literature, which we might touch on. So when you talk about, if you look at from a point of view of psychiatry, if you look at the short Oxford textbook of psychiatry, the book will describe grief as happening after bereavement. By bereavement, we mean the death of somebody we love. We lose that person by death. And that loss by death loss is bereavement. Grief is a reaction we get because of bereavement. And that's your textbook description of grief. Having said that, I mean, we all are aware that in our day-to-day practice, we see a lot of grief that happens after loss, but it may not be after loss due to death. You could lose a person due to the person might migrate. A woman's daughter might get married and leave home, and the mother might experience grief, even if she has planned and arranged that marriage for that daughter. And we see this sometimes more in our South Asian context. We could feel grief after the loss of a thing or retirement, for example. The concept is you have lost something or someone that is very dear and very important to you. And that reaction to the loss is what you get as grief. The other word the trainees particularly will hear tossed around is this word mourning. Mourning goes hand in hand with grief. Grief is emotional, you can't control it, it's behavioral, it's something that comes from inside of us. Mourning is what society gives to us from around us based on our culture, our background. Mourning is the cultural processes that happen when we lose somebody. Okay. So and it's mourning, as we know, happens differently in different backdrops. This is a very South Asian scene, a scene of a funeral, and you can see the manner in which the funeral happens as well as the crowd. So there's a lot of people there. Whereas this is a different cultural background where people might engage in mourning quite differently. Sorry, can I ask whoever it is to mute themselves? Thank you. Okay. So when you look at the textbook will tell you that grief happens in different stages. And again, but having said that, in truth, if any one of us has experienced grief, you'll know that it's a continuous process. It's not something that you can break into bits. But artificially, for the sake of description, we do divide it. And the divisions that I described to you now are what's described in the short Oxford textbook of psychiatry. So the initial stage, now if you were to understand this, to try and imagine this, imagine you have a husband and wife, and the husband goes to work in the morning, goes to office, and then at about 12 o'clock in the afternoon, the wife gets a phone call that this man, something has happened. He's had a chest pain, a heart attack, he's been taken to hospital, things have not gone well, he's passed away. And what's the woman's first reaction when she hears that? The first reaction is, it can't be. I packed him a lunch. I spoke to him in the morning. We are going out again in the evening today. So that initial reaction to that terrible loss is denial. And that's a very natural, almost protective reaction that we get when we first hear the news of the bereavement. It could be, you could describe it as a sort of temporary defense. And usually it moves on to acceptance or partial acceptance. But that first reaction to hearing somebody has died is often denial. But of course, it can be very brief. It can be a few seconds, minutes, hours, maximum. That if it goes on for much longer, then there is something wrong. So what happens? What happens next? You hear the news, you feel the first reaction is, it can't be. This is not possible. It didn't happen. This is just a bad dream, bad news. They're talking about somebody else. But then this woman who heard this news, this example that I gave, she goes to the hospital. More people keep telling her this happened, he came, he got a pain like this is what happened. She sees the man in hospital, and gradually the inputs, the repeated reiteration that this has happened leads her to move on to what we describe as the next stage of grief, which is you come to realize this is true. This has happened. I can't turn a page back and go back and make it not true. And that's the really difficult thing about death and losing somebody by death, because you can't make it unhappen. You can't go back and talk to the person again. You can't meet the person again, say anything different, do anything different. So that leads to a lot of reactions in that person. And the textbook will tell you that for the next 6 months or so, this person will go through this next stage of grief, where they experience waves of sadness, grieving for that person who's not there anymore. They might be preoccupied by the dead person, also have lots of mixed emotions, have some features like somatic symptoms. They can't sleep, they can't eat, and they might also have perceptual disturbances. So this is the symptoms are typically more in the early stages of grief or in the early months, and with time they are supposed to get less. Now I know this is a lot of words, and it's sometimes difficult to get your head around it unless you've been there. So there are lots of people have described grief. I thought I'd just look at how some people have described this experience of grief. I'm borrowing from the Indian subcontinent here, and I'm sure everybody knows this author. He's a great author. He wrote this book. R.K. Narayan wrote this book called The English Teacher, and it is a beautiful description of grief. In the book, it's basically about an English teacher, a young man, and he gets married, I think, through a proposal to another, a young woman from the village, and they get together, they come to the town, they have a child. When the child is about 4 or 5 years old, the wife gets typhoid and dies. And much of the rest of the book is about his experiences with, how he goes, how he reacts, how does he get on with his life after his wife dies. And it's worth a read. This is a little bit, I've just put a few excerpts of how he describes this. So he says, this is soon after his wife's death. After the funeral, that was over, people have gone away, now he's at home. The days have acquired a peculiar blankness and emptiness. So he's not even saying he's sad, he's just feeling flat, empty. And then the biological features. He can't sleep. And when he can't sleep in the night, he's thinking, he's remembering his wife. And then this is interesting. In the darkness, I often felt an echo of her voice or speech. And sometimes her moaning and delirious talk in sickbed. So people often can experience fleeting hallucinations in grief, which is of course often connected to the loss. It's linked to the person who died. So here he's remembering hearing the wife's voice and remembering how he looked after her when he was sick. She was sick. In another place, this is a different part, also after the funeral. I just put it up because I thought it was interesting, because sometimes it's difficult for us as outsiders to know how do we react to somebody who is experiencing bereavement. And so he says, condolences, words of courage, assurances. I had got so many of those. I had become a professional receptacle of condolence and sympathy, and I had received them in such quantity that they ceased to mean anything to me. So he had sort of become numb. I just thought that and he's probably numb and not reacting much. But again, an interesting take. So, and although this book is a book of fiction, the author, Narayan, also lost his wife when he was young. So I think he was drawing on some of his experiences when he described grief. I wonder if you've heard of this book. This is also another book. This is a book from Sri Lanka that is a very powerful book, all about grief. And the grief, this is written by the woman who experienced the grief. Her name is Sonali Deraniyagala. And it's called Wave because what happened to her was a very exceptional tragedy. She was a young woman who was married. She was a Sri Lankan woman, but married to an Englishman with 2 children under 10. And in December 2004, they had the misfortune to be in Yala in Sri Lanka on the coastal belt when the tsunami hit. And in that tsunami wave, they all got tossed away by it, but she lost her husband, 2 young children, and both parents. She was a sole survivor. And this whole book is about her experiences after that loss. Now, that kind of loss it's grief beyond what we would, any one of us would really ever want to go through. But she describes the different stages quite beautifully. The initial stages were of extreme distress, depression. She had suicidal ideas. And with time, it evolved, but she goes through different stages. I'm just again giving a few excerpts. And here now, she says, for 3 years, I've tried to imprint "they are dead" on my consciousness, afraid of slipping up and forgetting of thinking they are alive. So again, now, the book will talk about grief for 6 months. But when you have a really bad loss, and a loss of a child is one of the worst, it can go on for a long time. And here she's describing the difficulty in accepting the death. Because her mind says, it's not true. And she's telling herself they are dead. And then on the top of it, after doing all of that, she says, I can hear a voice from the back of the car saying, it's a school day tomorrow, Mom. And if I so she's basically experiencing or re-experiencing the sense of having her little boy with her, going to school in the car with her. So this is, and you can imagine, so it's really, so re-experiencing the sense of the dead person with them, often remembering the person, grief around that, around the people that you lose. Or these are all examples of what we call the second stage of grief. I put this up because this is also from Sonali's book, that she talks about how her emotions after they died. And now you expect sadness, feeling bad. But here she talks about shame. And that is something also that people who lose, sometimes they might feel shame, guilt, self-blame. And here she says, I am aware of the shame. There must have been something very wrong about me because they died. So these are my constant thoughts in those early months after they died. Oh, I thought I must have been a murderer in my previous life, and I'm paying now. And even as I dismiss these thoughts, shame remains a huge in me. So she blames herself, she has guilt. And also, though she hasn't described it here, the other thing people often experience is anger. Okay, when you lose somebody, especially if you lose them unexpectedly or in a way that you feel is unfair. I think Elizabeth Kubler-Ross, I just wanted to mention her name because she's so well known. And I'm sure you have heard the name. Sometimes now she's also very well known. She did a lot of work not with actually bereaved people, but she worked in a hospice for the terminally ill. So with people who were dying and knew they were dying. And her book is full of her interviews and experiences with these people who were dying, how they were reacting. And she described the 5 stages that they go through. And sometimes people refer to this as the stages of grief as well. But actually her work comes from work with the terminally ill. So although this is for the trainees again, the short Oxford textbook of psychiatry will talk about 3 stages of grief. Denial, the second stage that we were spending some time with now, and then the stage of resolution. Kubler-Ross talked about 5 stages. This is just for your information. And, she talked about the initial denial that we mentioned, but also then she said people get angry. Then they start bargaining with their God, saying, if I do this, so if this happens, then let me live a month longer. And then you get to accepting and getting upset and depressed. And finally, acceptance at a sort of, level of acceptance without the depression. So she described these 5 stages, but in people who were terminally ill. Sometimes it's now also used as to describe grief. Okay. In the three stage classification, this anger, bargaining, depression, all of that goes into 1 stage. It's denial, stage 2, and then finally acceptance. Could I ask anybody who is, thank you. Sorry. This question now, I know as psychiatrists and psychiatric trainees, we see a lot of people grieving, but do we see grieving people in our work and not realize that they're grieving? So what we might see is people in the second stage, maybe they are a man whose wife died 2 months ago, comes and blames the doctor and, is abusive, verbally abusive, blames, threatens to go to court to a point where it's unfair. But that also, unless you recognize this possible grief and the different emotions that he's going through in grief, you may not understand where he's coming from. So this is just a thought that because we work with a lot of people who have undergone grief. Some of it we know that they're grieving, but sometimes we don't realize. By the way, and then the book will tell you, after people have gone through that stage, they will finally come to this last stage of, accepting the loss, adapting to life without the dead person. Again, many people resolve their grief in different ways. Perfect resolutions may not always happen, and reminders are always painful. As Sonali Dhiraniyagala talks in her book, she said now she's, I think, 10 years after the death, 10, 15, 12 years after the death. She says, still, when I know that the boys' birthdays are coming, the months before the birthday, I get upset, I get anxious. And at the birthday, it's terrible because I'm thinking they would have been like this at this point. So, but at other times, she has moved on. Even she has created a life for herself. By the way, if anybody has questions, you're free to ask, jump up and down. And if there's anything in the chat, I'll check on it at the end. Okay. I think the answer to this is fairly straightforward. Yes, it is a normal, universal phenomenon, grief. And does it need medical help? Most of the time it does not. And usually, depending based on where you are, support from your family and friends in the community is more than enough. But a small caveat, take the person's individuality and circumstances into account, because although grief is universal, each person's grief is also slightly different. How a person grieves can be different based on how they've been brought up, their own personalities, the culture. Okay, so each person grieves in their own unique way. I want to touch on when grief becomes abnormal, and that's something that we need to think about. And I thought I'll give you an example. These are people I've seen in the past few months in my work, in my clinical work. So this is Mrs. Savitri. She's 65 years, and she came to she's diagnosed to have bipolar affective disorder, stable on treatment. She's been ill for years, but stable for the past year or two. Brought by her family because her adult daughter had died of cancer, breast cancer, about 2 months previously. And when the family were worried, because now this Mrs. Savitri was saying that the daughter is alive. So she was not accepting that the daughter is dead, and also upsetting the family was that she was claiming that the husband and the son have, plotted to hide the daughter from her. She has a sham funeral. Okay, so complete denial of the daughter's death is what we saw in this lady. So that first stage, and this was 2 months after the death. No? So that first initial reaction of denial in her was going on. It was also going on, and she had now evolved psychotic symptoms. We checked, because we obviously thought maybe she was depressed and psychotic or manic and psychotic, but no features of a mood disorder. Calm, cooperative, euthymic, but claims this, which is really interesting to see. So it looked a lot like a prolonged denial. And that's just an example. So when you look at abnormal grief, it's classified by duration and intensity and nature. So you can have delayed grief, where it's too prolonged, the first stage is too long. You can have, so we call delayed because the person doesn't go into real grief when they should. They don't go into that second stage and feel the grief. They keep hiding from the grief. So the true grief is delayed. The second one you'll hear about is prolonged grief, where the grief goes on for longer than 6 months. Again, you can debate this whole 6 months business. I mean, does anybody get over anyone in 6 months is a question you can ask. But if you see somebody who's been grieving prominently for years and years, and that impairs their functioning, then you have a prolonged grief. Or unusually abnormal patterns of grief, or very intense grief, or grief where the person meets criteria for depression. That's also another way you can get complicated. And at least in Sri Lanka, the trainees often get harassed with this question. How do you know it's grief? We will ask them. How do you know it's depression? Why can't it be grief? When somebody has presented after the death of, say, a woman presents after the death of a mother, and the trainee suggests that this is depression rather than grief, you will be asked, Why do you say this is depression as a disorder or an episode? Why can't it just be grief? Because grief includes sadness, low mood, loss of appetite, loss of sleep, a lot of features that we see in depression also. So there are some differentiating features. The key thing with grief is that it's all about the loss of that person, all about the person who died. So in depression, you get more. So one thing is severe psychomotor retardation. You're very unlikely to see in grief, much more in depression. Also in depression, you can get this global sense of hopelessness, worthlessness. It is not limited to remembering the person, or it's not limited to situations which we shared with the person who died. This is all the time, when at home, at work, at other places. So whereas when it's grief, so the first example I gave you, the woman who lost her husband, about 3 months after the death, she might find when she goes out, say, to work herself with her colleagues, she forgets temporarily, she feels better. When she comes home in the evening, when she and her husband used to sit and watch TV together, she feels terribly lonely and sad and remembers him. So that's typical of grief. Whereas in depression, if she was depressed, going to work would also be difficult. And at work also, she would feel stuck. And, I can't work, I can't concentrate, I can't focus. And prominent suicidal ideation in all situations or in many situations again suggests depression, because in grief, it can be there, but it's usually fleeting and with ideas of sort of rejoining the lost person. So it's the pervasiveness and the nature of the symptoms that differentiate the two. So if you think about when does a grief become complicated? What makes it more likely? I've given a picture there as a hint, and I think that's one of the most difficult losses. If you lose a child, if your child dies by death, dies and a parent loses a child, any age, especially an adult child, but any age, it's a really difficult thing. It's probably one of the worst things that can happen to you. And we hope that it would, even thinking about it is too difficult to think about for us. So, but how do you face it if it happens? I mean, how can you even expect that mother or father to ever recover from the grief of the loss of a child? So, and this is what... Hello, can I ask to mute? Thank you. So when I talked about that initial lady, Mrs. Savitri, the bipolar patient who came with denial, she was denying the death of her adult daughter, and denial was easier than accepting the death, and that's why that was happening. Other reasons for complicated grief might be, an unexpected death. Don't forget, we also see a group that we forget, when not just unexpected, but the manner of the death can also cause difficulties, particularly losing somebody by suicide. If your brother or your husband or your wife dies by suicide, where does that leave you? What sort of complicated emotional reaction do you get in your grief? And that is something that we see and we need to be aware of. These are things you will already know. If the person herself or himself can't grieve, or the other interesting thing is if they have a difficult relationship with the person who died. You might think that if somebody has a good relationship, they're very close to the person, they have a good relationship, then they should be more sad and have a more difficult relationship when they die. But that's not true, because if you have a good relationship, even when the person dies, I cared for the person, but they cared for me. I did what was necessary. We were good to each other. Whereas if you have a difficult relationship with somebody and you're close to them also, and they die, you can't go back and correct things that you want to change. You might think, I wish I hadn't, I wish I had treated him better. I wish I had not done that. I wish he had not done that. I wish he had been kinder to me, but I can't go back and fix the relationship or ask him to change. So then that causes that ambivalence that the difficult relationship causes. So that causes grief. So it's the difficulty in the relationship that translates into a complicated grief. Obviously, if somebody has a history of a psychiatric disorder, then your risk of pathological grief is much greater. And this is just for you to know. The important thing is mortality rates are increased in people who are grieving in the first 6 months, particularly when it's older people who are grieving. This was just another example to wake you up. This is, we recently saw a 20-year-old girl called Menaka who came after a paracetamol overdose, not a very high intent one. Her mother had died of a road traffic accident when she was 14. But that's not why she came. She came because the father was blaming her, saying she keeps getting into all these unsuitable relationships. She keeps finding boyfriends and without focusing on studies. So fairly standard complaint from the father. Okay. When we saw her, she was depressed. So we talked to her about the relationship with the boyfriend, because that's what the father is worried about now. But then she said, she's not too fussed about the boy. She likes him, but he hasn't called for a while. She's okay to stop it. But what she said was, she had stopped talking to him, but she's still in contact with his mother and his family. And his mother calls her Dua, as in daughter in Sinhalese. And when we traced back, we realized that she keeps getting into these relationships, but it's not just the boy, it's the package that he comes with. It's the family and the mother that she keeps getting close to. So although there is depression here, you can see the unresolved grief coming in here, that second stage, the yearning for the mother that she has lost, and how she, without realizing it, keeps looking for her mother in different ways. So, could I just ask people to mute? Thank you. So that was it was sad, but also interesting to realize this about this girl. And so you would then need to incorporate that when you're, helping her to get over this. So if you're looking at how do you treat pathological grief, the overall concept is recognize where this person is stuck. Are they stuck in denial? Are they stuck in processing their grief? And then try to help them work through that. If it's denial, how to accept that it's real. If it's, they haven't processed it yet, how do you help somebody then accept that it is very painful and it is very difficult, but you have to go through that pain and then move on to a time where you are living without the person who died. So you have to recognize the person, the individual, the circumstances, and tailor your therapy. But these are the broad sort of concepts. So you're trying to help the person to come to terms and accept the loss, accept it, go through the grief, and then work through it. You're also trying to help the person to build up a new life without the person who died. And that can need behavioral activation. It may need practical problem solving, depending on who has died, who they're living with, things like that. Okay. And then pharmacotherapy, obviously not for grief per se, but it can be very useful if there is psychiatric comorbidity like depression or alcohol misuse. So it's this combination that's said to work the best. Recognize what stage the person is in and try and help them process, either accept the loss or process it. So pharmacotherapy if needed, activity. So for Menaka, like I said, who was still looking for her mother in every relationship she went to, it's starting with acknowledging that and then trying to work through that, which is harder. Okay. And it's sometimes, now trainees, you might be familiar with situations where we say, if the occupational therapist will say, so if you're to do grief work, ask the person to bring a photograph of the dead person and look at it. So it's not just doing that. You need to understand what's the concept behind it. If you're asking a person to look at the dead person, you could be, helping them. One thing is to accept that the person is no longer there, and also remember the person and experience the pain, so that you grieve, and then that will be the start of moving on. But it's difficult. And so grief therapy can take different forms depending on the person. So the book Sonali Deraniyagala, who wrote the book Wave, that book was part of the therapy that she was doing to come to terms with her grief. She didn't start it as a book. She just wrote her feelings because that was therapeutic for her. And it was several years later that she, because it was so descriptive, they put it into a book and published it. So you tailor your grief work depending on the patient and the situation, but do no harm. So little is known about, there's not a lot of research on the efficacy of grief therapy. Not a lot. And we really don't know some things like how effective, and also things like what's the suicide risk in complicated grief? We don't know that. So if somebody's looking for a project, though it's a bit difficult to do, something to be done. So finally, grief is a normal human universal experience, and our role would be, if necessary, to help the person process the grief and move on to become a person who lives without the dead person. So, can I ask you to begin? So, I'll leave you with that. This is a poem written by a man who was, again, this is about grief, about the poet is writing about his reaction to a man who died, about his close friend who died. And that's, the poem is by Auden. It's all about, again, it's grief, but a different style of expressing grief. Okay. So I will stop with that. I hope I have not gone over time. And I'm happy to take questions or comments if necessary. Thank you.
Thanks, Thilini. I think everyone was glued, and it was very, very interesting, not only for the trainees, so I think even for us as consultants, you managed to put it all together beautifully and gave it a very personal and sort of at-home feel to the whole thing. We have quite a few questions. Are you okay for me to read them out so that we can take them?
Yes.
One by one.
Dr. Sauri, please proceed.
Yes. Yes, of course. Thank you, sir. So the first question was, what's your take on the personal grief on losing his or her patient who dies of suicide while on active treatment? That's one of the first questions. Thilini?
Dr. Sauri, please name the who question actually.
I think it's
if possible.
Somebody calls, it's Sudip. I think Sudip. Is it?
Yes. That's right. Sudip Som. Yes.
Yeah. So, I think that's it's a really important question, and it's something that I think all of us have gone through or will go through as practicing psychiatrists and psychologists. It's grief, but it's a grief it's also in a funny sort of way. It's different because you don't actually, so grief typically is about you lose somebody you love. So you don't, I assume, love your patient, but you have a large commitment to your patient, and the emotional reactions you would get if this was a discussion, I'd be asking the trainees, what sort of reactions would you get with it? But I think one of the obvious things you get is, you get upset. Guilt is a large part of it. Did I do something wrong? Was it my miss that this person died? And also blaming yourself for some, it may not be your fault at all, but you might take on too much responsibility for it. And it can have a reaction, even an adjustment reaction, an acute sort of stress reaction, can't sleep, feel bad about it, get overly cautious in the next few patients. I think we can all get that kind of reaction. By the way, there are many people here who are also very experienced in this field. If anybody wants to chip in, very welcome.
Thank you, Thilini. I think it was very nice. I'm just thinking, I think I saw a few questions also on the neurobiology of grief and depression. And I see Dr. Mohandas as well. Sir, do you have anything to say in terms of the neurobiology? Yes, you're an expert in this area.
Yes, sir.
And nothing more to add. It was an excellent presentation with more than 160 people attended. That's a great thing for SAARC Federation. Now,
Thank you, sir.
Neurobiology of almost all conditions are interlinked. The reason being, grief is a normal reaction for a loss, and it usually subsides. We usually put it in several stages in slow. Then there are so many terms of type of griefs. What is prolonged grief, protracted grief, complicated grief? I mean, Thilini has already told. Some people say disenfranchised grief. Some people say vicarious grief. That means just hearing some story of something, you feel sad. For example, as Sheehan Williams, hearing a sad story of somebody, he also feels grief to that. That is a vicarious type of thing. It is almost like a compassion fatigue. We talk in organizational psychological medicine. That is one side. So is it PTSD? The problem with the so-called PTSD, unfortunately, though our diagnostic classification was phenomenological, some terms have come into etiological classification. That is why post-traumatic stress disorder, PTSD, many of us will not. That so grief is, or the reaction, whether complicated, is a phenomenological thing for any trauma for that matter. Thilini's many descriptions are almost like a PTSD, some of them with the flashback reactions and etc. PTSD also, the phenomenology also is changing with the different classifications. I will not go into details. Only difference is depression, we know the neurobiology. Grief is a normal reaction. Initially there is a detachment, there are correlates. PTSD, it is little bit different. The flashback reaction neurobiology is different. I don't think this is the platform to talk on neurobiology of PTSD, neurobiology of depression. Subtle differences there, but they are all mixed. Okay, they are overlapping. The treatment really differs. The PTSD with the flashback reaction, treatment differs. It is not the antidepressant that we give. I mean, what happens, the noradrenergic response rather than the serotonergic response. I will not talk here much on it. Okay, thank you very much. It was an excellent presentation.
Thank you, sir, for your valuable insight.
Dr. Mohan Isaac also there. I think Dr. Behere and Dr. Nimesh Desai, as I know. Anybody wants to contribute, please. Professor Mohan Isaac, are you there?
This is Dr. Srinivasamurthy. Can I come in?
Oh, sir,
Yes,
please.
Yes, sir.
You know, thank you very much. It's been a very, very important topic, and congratulations to the speaker for a comprehensive presentation. And having read both the books that she has referred to, I can understand the issue. The area which I want to emphasize a little bit more and brought for discussion is the value of rituals in preventing abnormal grief reactions occurring. There is more and more recognition of this. I just recently downloaded about 10 articles in The Guardian, which came out. And one of them is a very interesting one. This is by the poet laureate Martin, who lost his son at the age of 18. And I just read out one paragraph. He says that, which is relevant to what we are talking about. And he says, what follows is not a menu. It is not a prescription. I know better than many that being told how to mourn is one of the most irritating things in the world. We each have to find our own ways of doing it. We can match, watch others do it, listen to what they say, but in the end, we have to make it work for whoever we are and whatever life situation we are. I would strongly advise people to read it, or I'll put on my email. If you send me an email, I'll send you all the articles covering that. The point which I want to make is that in our Eastern cultures, there are a lot of rituals relating to what you can do, what you cannot do. And this seems to be very, very protective. And again, there are some recent papers showing in Latin America, similar rituals are also protective of abnormal grief. We need to study them. We need to document them, not just glorify it, and see how we can bring it into the lives of people who are not living in big communities. See, all of these rituals were part of the larger communities when we were all living together in small villages or homogeneous communities. In urban areas, much of this is lost. So my own request to all the people in the audience is, don't look at grief only from the Western viewpoint. Look at it from the way it is experienced and how it is responded to in the Eastern cultures. Without glorifying it, see what is good about it. For example, I tell you, just end up with my point by saying, for example, in my community, for 21 days, the family doesn't cook. And all the food is brought by relatives for every meal, and the meal is shared by everyone. And every evening they read through a particular book where the soul is transiting to the other world. I mean, I thought it was a fantastic way of desensitizing and helping the people to do that. Similarly, for about 1 year, you don't wear new clothes, you don't do a marriage, you don't change a house, number of things, which means you are decreasing the number of social events, life events, adding to this one. And as you know, in the SRRS of Holmes and Rahe, death is the one which has the highest social readjustment rating scale. So I think it's a very important topic, both in terms of it becoming more and more relevant, but also an opportunity for us to rebuild our cultural strengths to address something without medicalizing it. Thank you very much.
Murthy, can I just comment on it? RS? Murthy?
Yes, please.
Yeah.
Go ahead, Dr. Mohandas.
Yeah.
I think that's a very important
almost
point.
10 years back, when the Tamil Nadu, the tsunami came, after that, there was a beautiful paper from Chennai regarding the resilience for the people who follow rituals and the prayers, the rituals and everything. And almost 10 years back, I had to speak in APA on spiritual resilience. And this is very valid, as Srinivasa Murthy has told. We have got these rituals, the prayers, these our own habits, our own cultural ethos really give a beautiful shield for circumventing many things. That might be the reason that we have got a reduced PTSD and grief. That I think Srinivasa Murthy has beautifully told it, and papers have come out from that. Sir, thank you.
Thank you, sirs. I think that's a very, very important point. In fact, improving resilience and preventing grief, we are in the context of the Turkey earthquake and then the mass sort of communities in grief. You know, societies, which is a common thing for tsunami, as well as in many parts of Asia where we experience mass grief following both man-made as well as natural disasters. And I think, as Dr. Mohandas said, we cope very in a very impressive way in most situations, and it's very much to do with our religious coping mechanisms, and it's something we need to really focus on more. Dr. Nimesh Desai, I see you here, sir. Anything you want to add to this conversation? You're muted, sir. You have to unmute yourself.
Just thank you. Thanks, Jan, so much. That presentation was superb, especially for me individually, the poem by Odin. But in continuation of what Dr. Murthy and Dr. Mohandas said, and not to keep repeating those aspects much more, but the other aspect that occurs to me is always that grief and bereavement is one of those soft areas which of course is very difficult in human experience, and yet scientifically for us mental health professionals in this part of the world, this is perhaps one of those areas where we need to be really treading carefully about normal versus abnormal. My concern for our part of the world about over-psychiatricizing the society and not to convert day-to-day normative experiences to psychiatric labels and medication. And so grief and bereavement are one of those areas where we really need, further to the cultural issues, so much more of that work. If I might also say, there is this whole issue of time limitation to normal grief. And that has bothered me. If I'm not making an error, in the 40 odd years that I've been in psychiatry, the normal grief definition has come down from what was 24 to 12 to 6 weeks. And it always bothers me, as the speaker said, at least the cognitive and the emotive or some ritualistic aspects of grief or remembering people who you have lost continuing, not to be seen as abnormal. And so it really bothers me that we kind of seem to mechanize the human experience to a time limit. And as everybody has said, it's such an individually different experience. I really think it seems to me that this talk at WPA Kolkata, Gautam, might be a very good idea. One of the research projects across SAARC Federation might be this area, really. That
is a fantastic suggestion, Dr. Nimesh. And we have the senior colleague like Dr. Mohan Isaac, sir, and also Dr. I.S. Reddy, the past president of SAARC Psychiatric Federation, Dr. Shobita Malhotra. It will be really great if you contribute something for a few minutes, because we have already past 7. And then Dr. Shauri and Dr. Rajapakse is there. They will conclude the session. And Dr. Dogar, I think, join, I don't know.
Gautam, Dr. I.R.S. Reddy here from Vijayawada. My request will be, this was so very practical and very simple, comprehensive. So why can't you think of inviting Madam to Kolkata for WPA so that the larger audience can be benefited for a same topic, probably in a little more elaborated way. I think it is practically very useful to all the people. I think many people have missed it. So why can't you consider it at a larger scale?
It is a really good suggestion. I actually thought so. I'll talk to Madam later and we'll decide. I'll decide.
Sure. Thank you.
And Dr. Isaac, Professor Mohan Isaac, sir, please.
Yes. Thank you. Thank you, Gautam, for asking me to speak a few words. I must tell you that I saw this announcement from Rajashree, and then I set aside time to listen. And I must tell you why. And the reason is, 2 years ago, I think before COVID, one of the Sri Lankan Psychiatric Society, Psychiatric Association meetings, which I had the privilege to attend, there was a keynote address, or I think an oration, by Dr. Thilini Rajapakse. He made a very impressive, very good. Thilini would, of course, remember the oration. It was a grand oration. I had the good fortune to listen to that in Colombo. It was during the, I do not remember whether it was 2018 or 19. So when I got the flyer from Rajashree, I made it a point to tune in. I was not disappointed at all. I put 2 questions. I think it didn't catch the eye of the chairperson. I will now, since Gautam has asked me, given me a chance to talk, I will directly ask. If the time is up, you don't have to answer this. My question number 1, it is already put on the chat box. It is very difficult for the speaker or the chairperson to actually go through all the questions because they are bombarded with questions. My questions were, when should grief be classified as a mental illness? You don't have to answer this because Gautam has already said it's 7 o'clock. And the sub-question to that is, when are antidepressants indicated in grief reaction? As you know, I'll give you the background to this. During the, formulation of DSM-5, one of the most hotly contested topic was grief being included in DSM-5. Nimesh has already referred to it. Can you give a time gap? 3 months, 6 months? In fact, one of the persons who wrote very strongly against this was Arthur Kleinman, Professor Arthur Kleinman, who had lost his wife. And it was already more than 1 year, 1.5 years. He said, I will probably never get rid of the grief in losing my wife. It is as if part of me is already gone. And he was ridiculing this kind of time duration being fixed. Anyway, much has occurred after that. We have the DSM-5-TR and we have the ICD-11. In both, there is given specific criteria for prolonged grief disorder, and there are also given definite indications for when antidepressants should be started. Anyway, thank you very much. It was a great pleasure listening to you, Thilini, once again. Look forward to, many people have popularly opined that you should be invited to Calcutta. So I'm hoping to be there, and I hope to listen to you again. Thank you very much, Gautam, for asking me to say a few words. Back to you, the chairperson.
Thank you very much for all the very nice things said. Really appreciate the feedback. Thank you to all.
Thank you. Dr. Rajashree, please. Dr. Sauri. Dr. Sobita Malhotra, please. Dr. Oren Marala is also with us, senior psychiatrist of Dr. Ma'am, you unmute yourself.
Okay. Am I audible now?
Yeah.
I am audible now. Good evening, everyone. I joined a little late, but certainly I think the whole issue of grief, bereavement, and its recovery is extremely important. And I will just pick up from what Dr. Mohan Isaac just said. Medicalizing and every grief and every bereavement will not be in the right spirit, because human beings have considerable amount of resilience and coping to deal with these stresses, and one can handle it. And certainly I think people who have a subjective experience of it will speak differently. Psychiatrists and researchers versus those when we look at it from an objective objectively, looking at other person going through this, and then we tend to become little judgmental that how soon the person should have recovered from grief and how completely one should have recovered from grief. And whereas when you go through subjectively, as Dr. Mohan Isaac says about Arthur Kleinman, I can talk from my experience as well. You never recover from grief. Grief is something that stays as in you. You learn to live with it, you learn to deal with it, you learn to encapsulate it and keep it aside in some recess of your mind and carry on with your life. But then as long as it does not affect your working, functioning, and your day-to-day life, and so then this can be kind of considered as a resolution. But basically, if you open it up, it becomes and it remains as fresh and raw as it ever was. So I think we need to understand the pathology when we give it a pathological label. That is something which we need to really very clearly know and redefine ourselves. And certainly, when does it come in the domain of a psychiatrist? Psychiatrists can be helpful at any stage. There is no question. Grief, even if there is a very soon after bereavement, psychiatrists can be helpful at any stage of grief. But the intervention in terms of calling it a disorder is something which we need to really examine and see. And role of medication again. I would think the medications now, with the newer knowledge that we are getting about medication and how they work, have a very wide spectrum of effects. Medication would also be effective, but certainly a very important area. And spirituality is something that we need to be talking more and more in mental health. We have to we have not dealt with this dimension, and we need to talk more and more about this in mental health, and it is very, very relevant. Thank you very much.
Thank you, ma'am. One thing I am saying, sir, ma'am, actually what happened, I can explain from my own life. I lost one of my bosom friends, I think 20 to 22 years back. And after that, there is a grief reaction. It is as we described like that. But after some times, I think it will be so severe, I cannot work. In fact, my all doctor friends wanted to discuss with some physicians or something. They saw what is happening, because the physical symptoms are more. But then I started the antidepressant. I took antidepressant for a few months and it was good. And I think sometimes it happens that it is a clear-cut definition. Maybe it may not be in the diagnostic criteria. Sometimes it was a depression and the symptoms were totally, it is a fatigability. Depressive symptoms are there. Physical symptoms are much more. It is in my own personal experience, I am telling you. But that course of, I took almost 6 to 9 months antidepressants and I was recovered. And that is the thing, depression is there.
Yeah. Certainly.
Anybody else?
Can I come in for just a brief one? You know, there is one other aspect of the cultural resource which I want to refer. That is the stories and myths which are there. Let me just give an example. This happened about 30 years back. I was treating a lady with severe depression because she could not donate her kidney for her brother who was having a chronic renal. Everything I tried didn't work. Till I told her the story of Kisa Gautami. You know, her guilt was so severe. But once I brought Buddha and Kisa Gautami, you know, who brings her dead son and asks to be revived, and the Buddha says, get me some gingerly oil from a house where there is no death. Then I was able to make a breakthrough and take her further. So there are resources in our culture, in our myths and in our epics, which can be again used in helping people in addition to the medical things, which of course it is always there. Thank you very much.
Dr. Shane William, chairperson, sorry, we are discussing at random. Please, sir, please go ahead. And Dr. Dogar, Imtiaz Dogar is there, I don't know. Dr. Shane William, please go ahead.
Ian, unmute.
Yes, I need to thank everybody for all your contribution. Thanks for all the participants also for joining in and contributing and listening to Professor Thilini Rajapakse's lecture. Thank you very much once again, Professor Thilini Rajapakse. And again, I must congratulate Dr. Saha and the SAARC team for organizing this lecture, and I hope it will go from strength to strength, and we will have participants regularly and sharing particularly the rich content of the South Asian region. And that is what even Dr. Murthy brought out, in the sense of so many different aspects which are different from the Western outlook, which we need to develop and strengthen for our region and the practices we have as a group. So thank you, everybody. Dr. Rajashree Rai, I must sincerely thank you.
And big hand for our speaker today, Dr. Thilini.
Thank you very much for the opportunity and the invitation. And
Dr. Rajashree, you want to say anything to conclude?
It is absolutely. Thank you so very much. May I just request everyone to mute? Because as we talk about and we talk about,
is there for vote of thanks.
Okay. Sir. Dr. Waziul, sir, please, if you would like to say something.
I think he is on the way from India to Bangladesh.
No, I don't think. Yeah, I haven't seen, sir. Is that all right?
So please
I would just like to request all of
Dr. Arun Morales, sir, please.
No, you are not taken any question. There are lot many questions are there, not answered. In the chat box, you have a lot many questions which are not yet answered.
Actually,
there are so many questions, nearly 36.
Actually, I think ma'am will answer all these questions by their mail. Yes. That will be good because time is already over.
Okay.
Dr. Maral, you want to contribute something, please, sir?
No,
she has covered the president, immediate past president of Wisdom of Indian Psychiatric Society.
Yeah, somebody has asked whether it is secondary to death only. Not necessarily. It can be death of a pet. It can be loss of reputation, your property. So any loss can follow this one. Secondly, the loss during this catastrophes, wherein multiple deaths as well as property is destroyed within seconds. So a person who survives definitely has a different presentation compared to one who is losing single person. So that is what I want to say. Thank you. Thank you very much.
Thank you, sir. Rajesh, please conclude.
Thank you, sir. Grief is a universal phenomenon, and it is one particular emotion that none of us can escape. And as we talk about this in our CPD from the SAARC Psychiatric Federation, I would request all of us to remember in our prayers tonight all the departed souls of the Turkey and the Syria and the other countries who have been massive, and there are many people across the world who are facing losses in many ways. It's unimaginable. But we also should pray that grief should bring back a gift, the gift of return in terms of building our resilience, our coping skills, and our ability to stay with each other through whatever ways we find, whether it's through intimacy, endearment, friendship, spirituality. And with that saying, I would like to thank our sponsors tonight, Intus Group Pharmaceuticals, for hosting this platform, our President of SAARC Psychiatric Federation, our Vice President of SAARC Psychiatric Federation, our Secretary General of SAARC Psychiatric Federation, our Treasurer and our Editor, and all the senior members and advisors, Professor E. Mohandas, Sir, Professor Afzal Javed, Sir, Dr. M.S.V.K. Raju, Sir, for getting this whole platform together for us today so that we can interact, exchange our views, and help our generation and the coming postgraduates in a rich academic field across the boundaries. And as we say, it's beyond boundaries for all the 8 countries together. And of course, I would sincerely say the final thank you to none other than Sayuri, who has, she had selected Madam Thilini today for the first CPD session. And I would like to invite all of you to continue participating in these series. Do send us your topics and suggestions and volunteer speakers, because it's only when we work together that this will be a continuous series with great success. With prayers for all, thank you very much.
Before finishing, I want to say it will be coming country by country. I mean, next, another country, from another country, one speaker will come. That will be very good, country by country. And it will definitely, not only we learn out of the topic, but also learn in their cultural and social background. That is most important. Though we have almost all socio-cultural background, but still we can learn out of this. Thank you so much. Good night.